Hello people, in this video we want to look at primary angle closure disease, okay? So basically under this angle closure disease, they have three things. You have an angle closure suspect, then they'll go into angle closure and that will lead to angle closure glaucoma. We want to focus on angle closure glaucoma. Basically the angle is closed, the aqueous humor cannot drain, so there is angle closure glaucoma, which will have what? It will have optic disc changes and it will have visual field defects, right? That is what glaucoma is. In this again you have two types, chronic and subacute. Chronic is common, okay? So the angle is slowly closed for a long time and the person will land up in angle closure glaucoma. Subacute, acute, suddenly the angle will close and they will have glaucoma. So what is glaucoma? It is optic nerve change, visual field defects basically can be associated with raised intraocular pressure, right? So you have so many types of glaucoma, right? This is the classification of glaucoma. You have in primary you have congenital and adult. In adult, open angle glaucoma we have already seen. Now we are moving on to angle closure glaucoma. So PA angle closure glaucoma, PACG, okay? We are looking at this one, okay? So raised intraocular pressure means how much? It should be greater than 22 millimeter of mercury, guys. How many millimeters of mercury greater than? It should be 22 millimeter of mercury. If it is, then you can say it is raised intraocular pressure. Basically, what is normal? Normal is 16 millimeter of mercury average, okay? Average. So we need to look at everything about this. Where is this angle? How is it closing? What happens? All that we need to look at. So orient yourself. Here's the eye, right? And zoomed it here. Here you have your iris, right? Behind the iris, your aqueous humor is produced. That aqueous humor here from the posterior chamber, it gets produced. It comes out of the pupil, comes into the anterior chamber, and it is going out via the trabecular meshwork and the uveoscleral outflow. Two outflows are there, right, for this aqueous humor. Something happens here and this angle gets closed, okay? This angle gets closed and the intraocular pressure will increase. So this will lead to pressure, could lead to optic nerve damage, right? And then this person will have visual field defects. So look at the structures here. Iris, they have shown cornea here, outermost iris. Then you have here what? This one, they are showing anterior chamber angle. Okay, this is the angle, looks very small. And then here you have the trabeculum, and then here you have the Schlemm's canal, right? What else are they showing here? So look at the production of the aqueous humor here. That's what they are showing, how it is being produced and how it's being drained. So what are they showing here? You have the ciliary efferent vein. And here they are showing aqueous coming out of the pupil and it is going where? Yes, guys, it is into the trabecular meshwork, then the Schlemm's canal, then it's going to the aqueous vein. Okay, that's an interesting name. Then you have the intrascleral plexus, then it is going to the episcleral vein, then it is going to the anterior ciliary vein. So guys, it is going where? Into the veins, okay? So guys, how will you know that this angle which we are talking so much about, it is open or not? How will you know? So basically, look at this here, you will do gonioscopy and you can see some things, right? What can you see? You can see Schwalbe's line, right? SL, then you can see trabecular meshwork, then you can see scleral spur, then you can see the CBB, that is the ciliary body band, and then ROI, that's the root of iris. So root of iris you can easily see here. This root of iris they have shown here, right? Root of iris. Then the ciliary body band. Yes. Then you can see the, what is SS? Scleral spur. Then you can see trabecular meshwork. And then you can see the Schwalbe's line. So there is some mnemonic for this, right? I can see. Yeah, I can see the stuff. So this is iris, root of iris, CBB, ciliary body band, S is what? Scleral spur, trabecular meshwork, Schwalbe's line. Okay, there are two S. You'll have to focus on that. Schwalbe's line is anterior most. Okay, and based on this, they are telling you the angles. Okay, whether these angles, how will you say? If you can see all of these 1, 2, 3, 4, 5, right? If you can see all of these, they're saying it's grade 4, grade 3, grade 2, grade 1, grade 0. Grade 0, you can't see anything, right? Grade 1, you can see 1 structure, grade 2, 2 structures, grade 3, 3 structures, grade 4, 4 structures, is it? Or 5 structures, wait. Guys, this is correct only. Grade 1, 1 structure you can see. Grade 4, you can see 4 structures. So what about that iris, root of iris? Why didn't they include that here? So only these 4 define it. So got it, guys? So you can say now that grade 4 is wide open. 4 is 40 degree, 3 is 30 degree, 2 is 20 degree, 1 is 10 degree. And grade 4 is wide open angle. Its closure is impossible. Okay, no need to worry about these people at all, right? And even for this 30 degree, they are saying open angle closure impossible. Okay, so 30, 40, grade 3, grade 4 all fine. Okay, only if you can see like Schwalbe's line and trabecular meshwork, all that, only you can see 1 or 2 structures, that will become a problem. Okay, risk of closure will be there. Is it fine, guys? What we are looking at, you understood about the angle, right? Guys, pay attention here to the aqueous humor drainage. There are 2 ways it will drain. Okay, one is via the trabecular meshwork, Schlem's canal, and all those veins, right? But there's yet another way. The ciliary body will absorb and then it will go to subchoroidal space. Okay, again into venous circulation. So it is going to the uvea, right? That is the ciliary body. That's why it's called as uveo. And then it will go to the venous circulation of the ciliary body, choroid and sclera. So sclera. So it is going to uveoscleral circulation. This one is trabecular meshwork, Schlem's canal. From Schlem's canal, where is it going? It is going to the veins only, right? Episcleral vein. So finally, it's going to the venous circulation itself. What do you say, guys? The main drainage is via the trabecular meshwork. So guys, when you look at the anterior chamber, how will you know, guys, whether it is deep or shallow? Look at this. You can see the angle is very open, right? So by oblique illumination, you can check, right? When you put the light from the temporal side, look at this one. When it's shallow, you can see here the anterior chamber is shallow here. The angle is less here. It's very shallow. So that time you see a shadow like this, right? So you are putting the light from temporal side and from on the nasal side you are seeing the shadow. So this is by oblique illumination you can know the depth of the anterior chamber. This they will teach you in clinical anyways. Look at one last diagram here, okay guys, because you will need these terminologies. See the iris position, right? See this is the regular position. What they have shown here is the regular flat position. Okay guys, then just learn something more, okay? Here you have the plateau position. Here you have the bowing forward and this one is the concave. Okay, so these are the positions of the iris. So guys, this is whenever the angle closes, right, it's just an angle closure disease. Only when it leads to optic nerve damage and visual field defects, etc., it becomes a primary angle closure glaucoma. Okay, disease is just this peripheral iris against the trabecular meshwork resulting in the obstruction of the aqueous outflow. That is the angle closure disease. Okay, so epidemiology, what are these? See, if you think there are 10 people who have some this angle closure suspects are there, that means they have this grade 2 or grade 1 probably, right? Then you'll have only one case of primary angle closure glaucoma. Okay, so for primary angle closure suspects, 10 of them, you'll have only primary angle closure glaucoma. So they're saying it's not at all very common, because even though there are, you have known they are suspect, there's just how many, 10% chance? Yes. Chronic primary angle closure glaucoma is more common. This we already told you, right? Chronic condition is more common than acute one. Okay. So you can screen people, right? So this one, angle closure one is more in Mongolian, who have very small eyes, I think. So in Mongolians, it is very common. But in glaucoma, guys, in glaucoma blindness, you have open angle closure and all, right? You have open angle glaucoma, you have angle closure glaucoma. In that, these people who have this angle closure glaucoma, right, they can go into blindness. Okay. Why does this angle close at all, guys? Why does this angle here close? Okay, this iris became some plateau position, etc. They are saying, look at all the reasons. Okay, basically, they are giving you some demographic risk details like female will have more some things, age, female. They are saying in old age only it will occur. Okay, female mostly. Old age means 60 to 70 they are saying. So you should remember where Southeast Asians and then Chinese. Can you say Southeast Asians? Chinese and Eskimos. Okay, mostly these people. Yes, so let us look at anatomical and ocular risk factors. So basically people who have short axial length of their eye, right? So let us say this eye is smaller, right? So what will be happening? The rays of light which are coming from parallel, they'll be falling behind the retina because the eye itself is small. So people who have hypermetropia will have a small eyeball. So what will happen? They will have a small anterior chamber. Everything will be small. So obviously the angle also will be small. So people who have hypermetropia will have short axial length. So they will be at risk for development of primary angle closure disease. Okay. Iris lens diaphragm is anterior. So something like the iris is anterior. So what will happen? The anterior chamber will have smaller space, right? Narrow angle of anterior chamber. Okay. So that's the whole thing that we are telling. Angle of the anterior chamber is narrow means what? Obviously it can go into angle closure. Plateau iris configuration, we told you iris will have so many places where it can be. If there is plateau iris, that is here. If plateau iris is there, then they are at risk of developing primary angle closure and heredity. Okay, so you can blame heredity. Now let us look at the mechanism of rise of intraocular pressure. Why it will rise? Because of pupillary block mechanism. Pupillary block. So from where should the aqueous humor come out? It should come out from the pupil. Now for whatever reason this pupil is blocked, so the aqueous humor cannot come out, right? So the pupillary block. So that is one of the reasons. The next one they are saying is plateau iris configuration. Then phacomorphic mechanism. Phaco means what? Lens morphic. That is the morphology of the lens. So the lens goes on becoming big. Right, big and big and big it's becoming. So it's pushing everything in front, and then this angle iris is going front and angle is becoming close. That time what will happen? The aqueous humor cannot drain. Aqueous humor will become more and intraocular pressure will become more. If intraocular pressure becomes more, there is pressure, optic nerve damage, and then there will be visual field defects. See, pupillary block mechanism, they have explained a lot. Physiological mydriasis, that is when you're reading in dim illumination, what will happen? What will happen if you are reading in dim illumination? You will open your pupil will dilate, right? So mydriasis, physiological mydriasis. Okay, then pharmacological mydriasis. You only gave some eye drops and you dilated the pupil. Pharmacological mydriasis. Then, so this can precipitate an angle of case of acute angle closure glaucoma. Actually, they are not using the word glaucoma here. It can precipitate an attack of acute angle closure. So the angle can close. Okay. So what are they saying here? Not just these mydriatics like you put atropine or phenylephrine or tropicamide, cyclopentolate, homatropine. Not just these. No, sometimes even other drugs can cause this problem like tranquilizers, bronchodilators, antidepressants, vasoconstrictors also can, like nasal decongestants, anti-malaria agents, antispasmodics. Lot of drugs can cause this issue. So mydriatics can cause this issue and other drugs also like bronchodilators, etc. Okay. So that kind of makes sense. Dilator, bronchodilator. So dilate pupil, something like that. Okay, then you can remember like that. Then pharmacological meiosis also can precipitate. So it's not just mydriasis, even meiotics. Huh? That's interesting. So pharmacological meiosis also can there. Which is the meiotic drug, guys? Pilocarpine and then ecothiophate. Very good. Then Valsalva maneuver. Somebody went to do Valsalva maneuver and they go into an attack of angle closure. Wow. Let's just list this here. Valsalva maneuver. What's the spelling of maneuver? Man. O-E-U-V-R-E. Okay. This is Valsalva maneuver. He's trying to swallow, right? By closing his nose and mouth. But then he wants to, what will happen? The pressure should come out of the eustachian tube. So they can Check patency of eustachian tube. So if the eustachian tube is blocked also, they can open it sometimes. Now what will happen? He went to do all this, and angle in the eye will get closed, and he will go into angle closure disease. Yeah. Okay, then. Yeah, look at this photo here, guys. Mechanism of angle closure glaucoma, a relative pupillary block, iris bombay. See, first pupil block is affected. First pupil synechiae, right? This is posterior synechiae. It's sticking to the lens, the iris. Then what is happening? Aqueous humor is not able to get out. If aqueous humor is not able to get out, iris is getting pushed forward. This is iris bombay formation. Then, what else are they explaining here? Appositional angle closure. So, because of this iris bombay, the angle is getting closed. So, that is the appositional angle closure. So, guys, they explain pupillary block a little more with some photos that you also can explain in the exam. Plateau iris also you can draw in the exam and diagram. Phacomorphic mechanism, we told you, lens size will go on increasing, right? Now, let's move on. Okay, so we are moving on, guys. So, the classification. So, what did you see? This you already saw. There is some ICE geo classification. So, this is International Society of Geological and Epidemiological Ophthalmology. What name they gave? Ophthalmology, okay. Epidemiological ophthalmology also okay. What is G? Geographical. International Society of Geographical and what name? International Society of Geographical and Epidemiological Ophthalmology. Okay, they have given this. Primary angle closure suspect. Primary angle closure glaucoma. This is the ICE geo classification. Then what is this? Traditional clinical classification. Oh, that's a different one. Okay. Traditional clinical classification is latent primary angle closure glaucoma, latent primary angle closure glaucoma, then subacute primary angle closure glaucoma. Guys, focus. Then acute primary angle closure glaucoma. Primary means what, guys? You don't know the cause. It's not related to some any other disease, known disease. Chronic primary angle closure glaucoma. Same thing only. Latent, subacute, acute, chronic. Okay, and chronic is the most common, right? You know that. Okay. So let us look at the clinical profile and management now of primary angle closure suspect. What to do is there, and if there's a primary angle closure, what to do, they will tell. Primary angle closure glaucoma, what to do. Okay. So basically everything is important. So how will you know a guy's angle has closed or not? We already told you, right? How you will check gonioscopy. You will measure the intraocular pressure with a tonometer, right? Tonometer. Yeah, then you will do what and all. You will do some ultrasonic biomicroscopy. You will check the anterior segment. You will do optic disc evaluation, visual field analysis, standard tests you will do, right? And here they have given some photos, guys, on what is this actually? Van Herrick method of slit lamp grading of angle width. So basically, they are just looking for angle in everybody. Then if they think the angle is small, then they will call them angle closure suspect. How to check for angle? That's what they're explaining here. Look at this. This is the slit lamp examination. Here they are explaining. CT is corneal thickness, guys. Where is CT? The first, this one. This is CT, corneal thickness. And then inside that, what will you see? Obviously, anterior chamber. So, anterior chamber depth. What is P? Peripheral anterior chamber depth. So, this is at the periphery, not at the center, right? So, the peripheral anterior chamber depth. So, what do you understand by this? This is grade 3. Where is grade 4? Oh, grade 4 is here. See? So, they are far apart. And this is getting closer and closer. The CT and the PACG lines are getting closer and closer. And here they are almost touching each other. So that's grade 0. So this is the Van Herrick method of slit lamp grading of angle width. When are they explaining this? In a how to look for a suspect. Right? That's what they are looking at. I think you can use this in everybody to check the angle. What do you say, guys? Anyways. See, guys, there are a lot of provocative tests. Okay. Prone dark room test. Then you have mydriatic provocative tests. A lot of tests are there. Anyways, basically your check is checking the angle. What is there? Check angle, check IOP, check anterior chamber, right? Depth. How will you check? By that shadow. You remember oblique illumination. Then you will do some gonioscopy. Then we will do what? Guys, focus here. What are we looking? You're looking for the angle. That's it. Optic disc you can evaluate, right? And then you can also check for visual field analysis. Okay. Then some ultrasonic biomicroscopy also. So basically, what are they doing, guys? They're just checking the angle. As simple as that. Move on. What will you do, guys, in these people if angle is at risk? Basically, you will follow up with these people. You can do laser iridotomy. Laser iridotomy means before it goes into any situation like this, in the iris itself, they will make a small hole. So that the aqueous can escape via the iris, that hole, iridotomy. Iridotomy you can do. So basically, you will make sure that prophylactically itself, you will make this hole so that these people will not go into glaucoma later. Now, let us say they are in angle closure. What will you do? First of all, how will you say they have gone into angle closure? Basically, there's some criteria, okay? So, the criteria says that you do the irido-trabecular contact noted on gonioscopy is greater than 270 degree angle. So, greater than 270 degree angle, there is contact, right? There is contact. So, that means it's blocked, looks like contact. Contact between what? Irido-trabecular contact is greater than this much. What is this? Irido-trabecular contact. Irido-trabecular contact is greater than this. Then only you will tell that yes, they have gone into primary angle closure, right? Then you will say intraocular pressure is more. Then also you can say that they have gone into closure. That's why it is becoming more. Then, or you can see synechiae, right? Peripheral anterior synechiae is present. So it is stuck. What is stuck? The iris is stuck to anterior synechiae means what? It is stuck to the cornea, is it? Wait, let's see. So this instead of sticking to the lens, right? That is one option, right? The iris can also stick to the cornea. Even then, there will be block, right? The aqueous cannot escape into the angle. So there will be raised intraocular pressure. So IOP can be elevated. There could be anterior synechiae, right? Peripheral anterior synechiae, PAS. Peripheral anterior synechiae, PAS can be present. Mainly, how is this different from glaucoma? That is what you have to say. Because the optic disc and the visual field are normal. That is what is important here. Optic disc, visual field, normal. As of now, it has not reached glaucoma stage. That is why it is primary angle closure. Angle is closed, but this person has not yet gone into glaucoma. How will you manage these people? What symptoms will these people have? They will have unilateral transient blurring of vision. Suddenly, vision will become blur. Colored halos they will see because the angle is closed and there can be corneal edema. See what is happening? This angle is closed, right? Basically, angle is closed. So now this is a primary angle closure case. Now these people can have sudden loss of vision also. They can see colored halo because corneal edema. Because of the pressure, corneal edema, they can see colored halos. They can have a self-terminating attack. This attack may just go away by itself. Because when they sleep or they go into bright light, their eyes will go into meiosis. That is, the pupil will constrict and the angle will open again and they become fine, right? With the vision, everything becomes fine. So this could be a transient attack. But this can happen again, right? So what will you do for these people? See, these people can have other symptoms also like nausea, vomiting, okay? Because of this pressure, pain, they can have nausea, vomiting, everything they can have, okay? So these people will come and tell you that they have had things like this before, right? Colored halos, they will see, lids maybe. Then what will you see as a doctor? You can see that their lids are edematous, the conjunctiva will be keymost, right? Cornea becomes edematous, insensitive. We told you cornea's edema will happen because of the pressure, right? Cornea will become edematous, because of which what they will see colored halos. Angle of the anterior chamber you will see will be closed. Then iris may be discolored. Pupil is semi-dilated pupil. So that is what is a problem, right? Then IOP will be more in these people. That we already told you here. See? IOP will be elevated. What are we looking at? Angle closure, right? We're looking only at angle closure. As of now, we are not calling it as glaucoma, right? So you should be able to distinguish this from other conditions. Like, obviously we said conjunctiva is chemosternal, so you should differentiate it from conjunctivitis, right? Basically that much at least you should distinguish. Acute conjunctivitis or a uveitis, acute iridocyclitis, etc. Okay. Then coming to treatment, guys, for these people, what treatment will you give? Can you talk about angle closure? What treatment you will give? You can give them anti-glaucoma drugs. Like in this case, you can give IV mannitol, then you can give glycerol, etc. Then you can give systemic drugs also, anti-glaucoma drugs, like what and all? To lower the intraocular pressure, you can give them carbonic anhydrase inhibitors like acetazolamide, etc. Then you can even put some topical anti-glaucoma drugs like beta blockers, alpha adrenergic drugs. What are the beta blocker drugs? Timolol, etc. Then alpha adrenergic drugs. Where are the alpha adrenergic drugs here? Brimonidine, apraclonidine. Carbonic anhydrase inhibitors, we told you acetazolamide, right? We also spoke about mannitol already. Mannitol is what? IV. It's a hyperosmotic agent. IV, they'll give mannitol, right? So many drugs are there. Then you have, they are mentioning prostaglandin analogs. Where is it here? The first one here is prostaglandin analogs. Then, so all the drugs here they are talking about. And even pilocarpine they are talking about, okay? Pilocarpine also. Next, what you will do if this doesn't work, you will have to do laser iridotomy, right? So you will reduce the intraocular pressure. See, in the other eye, you can always prophylactically do iridotomy even before attending to this eye, okay, which is affected. So you can do iridotomy in the normal eye and even in the eye that is affected. After this corneal edema and all comes down, then you can do iridotomy. So both the eyes you can do, okay. Then, if this doesn't work, they have filtration surgery. That's nothing but trabeculectomy, guys. So they will make sure that the aqueous humor will drain into the subconjunctival space. And if all this is happening because of the lens being swollen, they are even talking about clear lens extraction by phacoemulsification. And then they will remove this lens and they will put an intraocular lens, they are saying. Right? So they will put an IOL inside. So that will give some more, the thickness it will reduce, right? Because here they are using some terminologies called PI. PI is peripheral iridectomy, or you can have LI laser iridotomy. Such words are there here. Okay. Here in medical treatment, they're also talking about giving steroids to reduce inflammation, okay? Then you monitor IOP regularly, guys. Guys, you must see that there's something called as Vogt triad here. So basically, in people who have this acute angle closure, they can go into Vogt triad. That is, they can have this glaucum flecken anterior subcapsular lenticular opacity. So behind the anterior capsule, so that is anterior subcapsular lenticular opacity they can have. That is called as glaucum flecken. Okay. Then they can have patches of iris atrophy. Iris atrophy can occur in these people who have this angle closure. So next time you see a person with this iris atrophy, you can ask if there is history of angle closure, right? Then they can have a slightly dilated non-reacting pupil due to sphincter atrophy. So this is Vogt triad. So this anyway separate video is there, right? So Vogt triad you have understood. Where will you see it? In primary angle closure. So guys, we are done with primary angle closure suspect, primary angle closure. Now we have to go to primary angle closure glaucoma. Okay. So in glaucoma, what will be there? Optic disc changes will be there and visual field defects will be there. So basically angle closure glaucoma focus here, guys. They will have, what will they have? Everything will be there, same things, but optic discs will have changes, which is very similar to your primary angle closure open angle glaucoma. So you remember this cupping of the optic disc, the neuroretinal rim will go on becoming thinner and thinner. Then what you'll have, then there will be visual field defects very similar to primary open angle glaucoma. You remember that isopter contraction, bearing of blind spot, then what is this? Superior paracentral scotoma, this is tidal scotoma, this is arcuate Jerem's scotoma, this one is double arcuate scotoma. right? And here you can see the Roney central nasal step. So similar to primary open angle glaucoma, same types of visual field defects you will see here. Okay, you can see edematous cornea here. Remember, because of the pressure, there is edematous cornea. So this is acute congestive glaucoma. Here pupil should be, what is that, vertically oval, right? This is also important. And then how will you treat? Treatment is same. You will give anti-glaucoma drugs, iridotomy, PI, LI, filtration surgery. And finally, if it doesn't work, what will you do? You can also give glaucoma drainage devices. Glaucoma drainage devices. Wait. So glaucoma drainage devices also you can give. Like this is how it looks. See? They have some things like this, and that plate is kept here. And it is going to remove the aqueous humor from this chamber. Got it, guys? So that is also a possibility. Okay. Guys, one last thing the textbook says is this absolute primary angle closure glaucoma. Okay. So what is this? If you don't treat this primary angle closure glaucoma, it can go to absolute glaucoma. So what is this absolute glaucoma? Painful blind eye they will have, perilimbal reddish blue zone, caput medusae, cornea will be clear but insensitive, then anterior chamber very shallow, iris becomes atrophic, pupil is fixed and dilated, it gives greenish hue, optic disc shows glaucomatous optic atrophy, so it's going into atrophy, intraocular pressure is high, the eyeball will be stony hard, the eyeball can be stony hard, okay, because of so much of intraocular pressure. How will you manage this case, guys, of absolute glaucoma? You have to inject alcohol that will destroy the ciliary ganglion. Wow. Then, destruction of secretory ciliary epithelium to low. So, you are destroying what? You're destroying the secretory ciliary epithelium you're destroying to lower IOP. Okay. They are doing some cyclocryotherapy. So, that what basically they're trying to destroy. Okay. They're trying to use this cold minus 80 degrees or something, right? That probe to destroy the ciliary epithelium. Okay. Diathermy also they can use. That is high temperature. Is it either that or this one, or photocoagulation, light. So you'll use light and coagulate it. Finally destroy the ciliary epithelium. Okay. That's what they want to do. Then enucleation of eyeball. They're going to remove the eyeball. My God. Why? Because when pain is not relieved by conservative methods. Okay. So contains a malignant growth, then only they are removing it, is it? So the frequency with which a painful blind eye with high IOP contains a malignant growth justifies its removal. So they're saying that it can have a malignant growth, so they want to remove it. Okay. So did you understand, guys? Absolute glaucoma also we finished. So if this absolute glaucoma is also not treated, then what will happen? Corneal ulceration. So what will happen? That will perforate. Okay. Staphyloma formation, atrophic bulbi, that is ultimate ciliary body degenerates, IOP falls and eyeball itself shrinks. That itself will degenerate by itself and IOP falls and eyeball shrinks. So people, let us take a recap of this primary angle closure disease. Ready for recap, guys? So basically, we saw basic anatomy of these angles and how the aqueous humor is secreted, how it is drained, what are the two ways that it can drain via the trabecular meshwork, and the other one is the ciliary body. That becomes a uveoscleral outflow. Then we saw how to check for the angles, right? When you see that from anteriorly, you will see Schwalbe's line, trabecular meshwork, scleral spur, ciliary body, band, then root of the iris. So that is what you saw here. Basically, if you can see four structures, that is these four, that is the ciliary band, body, these four, okay, not the root of iris. If these four you can see, it will become grade 4. This angle will never close, right? Even if you can see 3, it will never close. But if you can see 2 or 1, it can close. So that is the grading, Schaeffer system of grading. So here you have 4 means 40 degree wide open, it will not close. 3, 30 degree, it will not close. 2 means you can see only 2 things, that is the Schwalbe's line and the trabecular meshwork. 1 means you can see only the Schwalbe's line. So there's high risk of closure, etc. If you cannot see anything, that means angle is closed, right? Then, what is this? These are the positions of the iris. Normal is this one. The regular, what is marked as regular? This is the normal, right? And then you have the plateau one, which you should know, which can lead to angle closure, plateau one, right? So these are some positions of iris. Then we saw how to check for anterior chamber depth. You would put oblique illumination and you can see the shadow here whenever there is shallow anterior chamber, right? Then, so basically we are looking at primary angle closure disease. In that you have three things that we will look at. That is primary angle closure suspect. That means this guy can go into primary angle closure. Then this guy has gone into angle closure and finally he'll go into glaucoma. Glaucoma means there will be optic disc changes and also the visual field defects he will have. Then only it becomes glaucoma. So we're trying to catch it early and classify them as suspect and closure, etc. Okay. So basically what did you see here? So why is the angle closing? Because the iris is going against the trabecular meshwork, resulting in obstruction of the aqueous outflow. So this is what is the angle closure. So basically for every 10 people who have a angle closure suspect, if 10 people are angle closure suspect, only one of them becomes an angle closure glaucoma. See, you saw a suspect, then you saw an angle closure, then you saw an angle closure glaucoma. If you have 10 suspects, only one guy will go to glaucoma. So it's not that big a worry, but anyways, they are screening people, okay, and in whom is it more? In Mongolians it is more, okay, this situation, because whoever has small eye, especially hypermetropics, they will have short axial length, right? So those people can have this, they can go into angle closure. People, especially 60 to 70-year-old females, Caucasians, Southeast Asians, Eskimos, Chinese, they can go into angle closure. They will have people who have a narrow angle of anterior chamber, who have iris lens diaphragm placed anteriorly, who has this plateau iris configuration which you saw. All those people can go into angle closure. Heredity also can be a cause. Some things, what exactly happens is pupillary block mechanism. So you saw that the pupil is from where the aqueous humor comes out. So pupillary block mechanism can happen because of mydriasis, which can be physiological or pharmacological, and even sometimes meiosis, pharmacological meiosis, and even Valsalva maneuver if people do, they can close their angle. Plateau iris configuration, we told you if you have a plateau iris, then also you can go into angle closure. Phacomorphic mechanism, the lens keeps becoming big and big and big, and finally what will happen when the lens keeps becoming big and big and big, the anterior chamber will become shallow and the angle will close. Okay. Then, so this they are explaining how the iris, the pupil is stuck to the lens, right? So this is what? Pupil block, and then there's iris bombay because the iris is getting bulged. And finally, because of this iris bulge, there is angle closure. So this is appositional angle closure. Okay. Then you saw some classification of this angle closure. So basically, what did we see? ICE-GEO classification, that is epidemiological ophthalmology, geographical. So something like International Society of Geographical and Epidemiological Ophthalmology. These people have made this classification, which you have already seen. Suspect will be there, then he'll go into angle closure, and then he'll go into angle closure glaucoma. Each of these you have to study. Okay, traditional classification, you have latent, subacute, acute, and chronic. Chronic will be more common, okay, remember, than acute and all that. Okay, so primary angle closure suspect, you will check for the angle, and then if they're suspect, you keep following with them, and prophylactically, if you want, you can do an iridotomy in these people. Okay. Then primary angle closure means what? The iris and trabecular contact, if it is greater than 270, then they're calling it as angle closure. If intraocular pressure is elevated, if there is an anterior synechiae of this pupil, then all these can become angle closure. That means they are in closure state, but they didn't still go into glaucoma. Because why? The optic disc cupping and all hasn't happened, and visual field is also normal. In these people, you will see something called as a Vogt triangle. That means these people, anytime that their angle has closed, they can have these glaucom flecken, anterior subcapsular, lenticular opacity. They can have iris atrophy, and they can also have a non-reacting pupil. This can all indicate to you that this patient previously had an angle closure. Okay. Then how will you treat an angle closure, guys? You can give anti-glaucoma drugs to lower the IOP. You can do iridotomy prophylactically and as a treatment, and then you can do filtration surgery, that is trabeculectomy, and also you can, if it is phacomorphic cause, you can remove the lens by phacoemulsification and put an IOL. Yes, these people will have colored halos also. Why, because of this raising intraocular pressure, there will be corneal edema. See, this will absorb everything, aqueous humor, and there will be corneal edema. So these people will see colored halos, okay. So basically, they will see colored halo, and this colored halo will, in a patient of cataract, it will break up. So that is the Fincham test. So you can do Fincham test to check whether the colored halo is breaking up and forming again, okay. In cataract, it will break up and form again. Cataract means which one? Primary angle closure. Any angle closure, if there's colored halo, it will break up and form again. Okay. So that also we have written here. Colored halo Fincham test. Okay. Then, now what will happen? Finally, this guy will go into glaucoma. If you didn't catch all this and treat and all, finally he'll go into glaucoma. Now, glaucoma can be chronic angle closure or subacute or acute. Okay. Here what will happen? Basically, you have to remember these things. This person will go into optic disc cupping, right? The optic disc cupping and visual field defects, very similar to what you have seen in primary open angle glaucoma. You remember these photos showing you bearing of blind spot, that isopter contraction. Then you have this superior paracentral scotoma. This is the idle scotoma. This is gerund scotoma. This is double arcuate scotoma with the Ronnie central nasal step, right? So similar, very similar. You will have in angle closure glaucoma also, same visual defects. Even their pupil can be vertically oval. Then how will you treat these people? Very similar to whatever you saw here, you will treat. And then you can also try some glaucoma drainage devices, something like this. Okay. Finally, if this stage also they'll cross, they'll go to absolute glaucoma. What will happen? Absolute glaucoma, stony hard eye and lot of congestion, redness. See this one, perilimbal reddish blue, even pupil is greenish hue. Cornea is having some what? Cornea will be insensitive. Anterior chamber very shallow, etc. A lot of things. Then how will you treat this absolute glaucoma? Alcohol you can give and destroy the ciliary ganglion. You can destroy the secretory ciliary epithelium with cryotherapy, diathermy, photocoagulation, etc. You can enucleate the eyeball if you think there is malignant growth, right? If there's malignant growth. If this absolute glaucoma you don't treat, then there can be corneal ulceration, perforation, staphyloma formation, atrophic bulbi. Even slit lamp can be used to check the angle and grade, okay? I mean to check the grading of angle. That is Van Herrick method. Look at this. See this, this is grade 4 when the corneal thickness, and this one is anterior chamber. These lines are far. It goes on becoming near, and when they overlap kind of thing, it's grade 0. Grade 0 where the corneal thickness line and the peripheral anterior chamber depth line both have become same, right? So did you understand, guys? So we are done in this video on this topic, primary angle closure disease, where we covered primary angle closure suspect, primary angle closure and primary angle closure glaucoma, right? And then absolute glaucoma also we covered. There is also something congestive glaucoma, that is also acute condition only. Guys, see here they have given how to distinguish this acute congestive glaucoma. It's just an acute condition, right? How will you differentiate it from acute conjunctivitis or acute iridocyclitis? Basically, in congestive glaucoma, pupil is large and vertically oval, right? This is sudden in onset. Yes, that is why it's acute. There will be severe pain in the eye, right? Pain will be there in glaucoma. In conjunctivitis and all, no pain, right? Iridocyclitis also pain, but this will be severe pain, okay? Then colored halo will be present. Okay, colored halo is present in congestive glaucoma. Even in conjunctivitis, it can be present. How will you differentiate the colored halo, which is because of conjunctivitis, which is because of cataract, and which is because of glaucoma? In glaucoma, in cataract, the colored halo will split up and form again. Conjunctivitis, basically other symptoms will tell you that it is conjunctivitis, right? Then you have the, you can see here the intraocular pressure is raised in congestive glaucoma. These people can have nausea, vomiting, prostration, they have written here because of the sudden pain, right? Anterior chamber will be very shallow. Then what else are you seeing? That's it. That's marked impairment of vision because in conjunctivitis and all, vision is perfectly fine, right? Iridocyclitis slightly impaired, but vision is hampered in acute congestive glaucoma.